Hi, everyone, and welcome to our Ask the Experts webinar. Today, we're going to be taking an interdisciplinary look at addiction. I'm Dr. Jamison Merrill, and I will be your facilitator for the day. And a quick look at our agenda. First, I'll be introducing our two panelists, and then we'll go through your questions and wrap up at the end with some final thoughts. And our first expert is Dr. Jennifer Fernandez. Jennifer, would you like to share a little bit about yourself and your practice?
Sure. Thanks so much for having me. I am an addiction specialist in San Francisco, California. I primarily work through a harm reduction psychotherapy lens, and then recently have put together some educational resources for folks who can't afford to be in psychotherapy on a weekly or more regular basis, and of course for folks who live outside of California who are looking for harm reduction resources.
Great, thank you so much, and thank you for being here today. And our other expert for the day is David Matthews. David, would you like to introduce yourself?
Yes, thank you all for having me. Again, my name is David Matthews. I am a licensed addiction counselor originally from the state of Louisiana. I'm also a registered substance use counselor in the state of California. I do provide clinical services for clients throughout the state of California through online remote therapy. And yes, we offer sliding fee scales as well. I'm also a adjunct addiction studies instructor as well with Oxnard College.
Fantastic. Thank you both so much for being here with us today. Go ahead and jump right into the questions. So our first question for today is, how do we get started with this community? Are there specific courses or trainings that the panelists recommend before ever starting working with those with addiction? And David, I'll have you answer this one first.
Sure. This is a pretty straightforward question, but I like it. There are many paths to working with individuals with addiction, and it can vary by state. For some individuals, I suppose traditionally, if they have already had a background in addiction and recovery, meaning that they themselves were, had an addiction or substance use disorder, they have found ways to use that platform to work with other members in their community to give back. As far as from a educational lens, you can actually begin working in addiction field with just a GED or diploma. Usually it'll be in the form of a technician position or something like that. For more higher positions, I should say, that would look like someone with a bachelor's degree doing like case management and addiction counseling. They're also for the more clinical positions, clinical and counseling. It usually requires someone to have a master's and some type of licensure. More so you see individuals that, like we have on the panel, we have psychologists, social workers, and other professional counselors who work with individuals with addiction. And again, it does depend by the state. There are varying levels of counseling, addiction counseling certifications. Like California has a few addiction boards, but there are many tiers to where you are as an addiction counselor. But what that means is that not traditionally, but you could take courses, starting out at a community college or university, and take specific courses to help you have more understanding of addiction. There are also continuing education credit avenues that you could utilize. That would be in the form of a webinar, professional conference, seminars, workshops. Those are ways that you can obtain the continuing education credits. But what is really required for an addiction counselor specifically is knowledge of the 12 core functions and 8 global criteria. This information can be found with SAMHSA through their TAPS 21 publication. It gives you all of the information that you will need in order to have those knowledge, skills, and abilities, or what is known as the KSAs, which is a competency that addiction counselors specifically utilize when addressing members in the community or for that particular population. But again, in having the education, training, which you can usually get through having clinical supervised work experience or just seeking out a external clinical supervisor, is all beneficial with helping individuals with addiction.
Great. And Jennifer, what would you like to add for this one?
I think in addition to what David shared with us, if folks are looking for specific modalities or clinical skills to apply with people who use drugs, I find that motivational interviewing is incredibly helpful to have on my tool belt of interventions. And any kind of training that's going to help us understand the change process and facilitate that process. I particularly like MI because it's evidence-based, it's a really compassionate and non-judgmental approach, and is really effective at helping people resolve their ambivalence, which is usually at least one of the obstacles that folks are facing when they're trying to change their relationships with substances. And then the other thing that I think would be good to have just a general education and information around is just psychopharmacology of specific drugs. So knowing exactly what ketamine is doing in my client's brain, the neurotransmitters that are implicated, things like dosage. That way I can sort of gauge the severity of their use. So if someone comes in and says they're using a gram of ketamine a week, and they're insufflating that, then I kind of have a sense of what the impact of that really is, both psychologically and on their physical health, as opposed to someone who might come in and say they're using like 7 grams a week or something like that, right? So understanding those differences for each kind of drug, for each class of drug, is really helpful, especially if you're going to work with folks at reducing their use. Whether that moderation is like the way that they achieve abstinence, or abstinence is their goal from the onset, I think it's really helpful to have that psychopharmacological background as well.
Yeah, great point that it's not just about learning the interventions and the theories behind this, but also being knowledgeable about the substances that are at play as well. Mm-hmm. Great. So moving into our next question, is addiction certification / training required when working with this population? So I know we touched on this already a little bit, but Jennifer, if you'd like to take this one first.
Yeah, I think David did a great job answering this question and kind of going through like all the different levels of certification and training that are possible. Again, it does depend state by state. So here in California, where I practice, we are required to take an addiction certification as part of the licensure process. So I think it just kind of depends on where you're licensed and your level of training. But again, always a good idea to have either some kind of consultation, some kind of supervision, some kind of training, webinar, continuing education, something to help you understand, because addiction is biopsychosocial. So we really have to understand all of the components, not just that it's behavioral, not just the psychological implications, but how it's affecting a person's biology as well. So a good idea to get some kind of training.
Yeah, and David, anything that you wanted to add there, or just any suggestions for somebody who's looking to go through that certification training process?
Take myself off mute again. Yeah, absolutely. It again, it does vary by state. Sometimes it may be a little bit difficult to secure a job without, or a position without having at least a credential. But I think now they're allowing you to start as a registered, which is like usually like the lower level credential before you initiate any type of work, um, or securing a position, I should just say. But yes, it, having that credential first, or applying for a credential first is beneficial, because it lets not just the client but other members in the community, as far as professionals or other service professionals, know that you are, going to be practicing within your scope. It may not be required again by the state, but it is helpful. So I would say, you know, yes, move forward with the credential, even though if it's not required, it may just be a preference, but definitely you want to have a credential at the very least when working with someone with addiction or who is in recovery. You again, usually you can secure these credentials through supervision, and that can be an external supervisor, or it could be somebody on the site of where you're actually performing services. So the best step is to, always look for information. All of this information can usually be found online, or just working with other individuals through word of mouth. But that, hopefully that answers that question.
Yeah, thank you. Great. And moving on to our next question, for those of us new to working with this community, when should we refer to a specialist? So particularly, how do you identify when this is out of your scope and what the right level of care might be for the person that you're working with? David, I'll let you take this one first.
Sure. You want to seek a specialist when you are not within your scope of practice, usually. So you wouldn't want to provide psychiatric, or if someone is presenting with psychiatric concerns, you wouldn't want to try to provide an intervention or therapeutic treatment that you're not familiar with to that individual, especially if it's, that individual doesn't really have a strong co-occurring disorder presentation or diagnosis, and that's another thing we probably will get around to. But usually, if you are not a some type of independent level mental health counselor, again, be it a psychologist, a professional counselor, or a licensed clinical social worker, usually that's when you want to refer or default to an outside specialist. Another thing that you learn quickly in behavioral health is, you always seek, if you're not comfortable and you're not knowledgeable, you seek the help of a supervisor or somebody who is more knowledgeable than you are. And not to look at that as a bad thing, but it's always going to be a client, or look at it from the client's lens. So use outside references, or even if it's within house, look for somebody who has a little bit more knowledge, be if they're directly above you or working right next to you laterally. They can probably give you some information. It'll help steer what you can do as a service professional agent.
Great. And Jennifer, anything you'd add to that?
I would echo what David said about, when it feels outside of your scope, feels outside of your clinical skill set, seeking consultation when you're feeling like you could use some more support in thinking about the case, or identifying interventions that would be helpful. Certainly if like countertransference is an ongoing issue with you for folks with people who use drugs, that might be something to get some consultation supervision around. Sometimes that can show up with like specific drugs that folks are using, or specific like subpopulations in the community of people who use drugs. And then in terms of level of care, I think when, working from a harm reduction lens, we kind of have a different approach to that, where it's really client-centered. And so, for example, if I'm seeing a client who I really think would benefit from inpatient therapy or an inpatient treatment program, I would definitely talk about that with them and let them know why I'm thinking that way, engage their interest and motivation around that, but wouldn't like force a person to do that until they were ready. So my job would be to help them resolve any ambivalence that they may have about that, to help them really come to terms with the reality of like the consequences that they're enduring because of their relationship with substances. So I think that may be a little bit of a different way that we work within harm reduction than other modalities of addiction treatment. But certainly, when you feel that their substance use is becoming so serious that you're really concerned about their physical well-being, like the long-term effects of their drug use, and you're sort of seeing that escalate over time, you're really concerned about overdose risk. You really are seeing this as a threat to their livelihood, or a threat to their loved ones, like if they have children or loved ones who are dependent on them, then that's when you would want to start thinking about a higher level of care. And so there, you could increase individual therapy sessions. You could refer someone to an intensive outpatient treatment program. Sometimes there are partial hospitalization programs, so they're going to treatment from 2 to 5 p.m., 5 days a week, something like that. And then inpatient care, which again has many, you can start at 30 days, 60 days, 90 days. So there are lots of options there. And I really like to present the whole horizon of possibilities to folks, so they don't feel like, I just have to do this thing where I have to leave my job and take 30 days off. And how am I going to afford that? And who's going to take care of my kids? And, so giving them lots and lots of options for what's possible is helpful.
Great, fantastic. And our next question, I know something that has come up for a lot of us: how has COVID / having to use telehealth affected each of the panelists' work with those with addiction? So working maybe in a different way or having to make certain accommodations, how has that impacted your work? Jennifer, I'll turn this one over to you first.
It hasn't affected much, other than just, being able to work maybe quite at the same depth relationally with folks. I think there's like a little bit that's lost there. It's not enough, I think, to make me personally feel like I have to go back in person. But there are some nonverbals that I sometimes miss out on. On the other hand, I just had an experience with a client the other day where they were sitting back a little bit further than usual, and I saw them like shaking their leg sort of anxiously, and I was like, oh, I noticed that, what's going on? And they were like, oh yeah, that's something that I always do when I'm nervous. And I was like, really? We've worked together for like 3 years. I've never seen you do that before. Oh, well, I control it when I'm around you. And I was like, oh my God, okay. Well, that would have been nice to know. So, in some ways it has revealed a lot about clients, and their space, their home, but for me, again, there's not a lot of like, we don't do UI testing or any of that kind of stuff. So it hasn't affected those kinds of interventions because we don't use them. And I find that it has made it a lot easier for folks to attend more regularly. There are less cancellations, less tardiness, things like that. So it's been kind of a blessing in disguise to be virtual with my caseload with my clients.
Yeah, so missing out on some of that in person, but getting some additional context and accessibility there. David, what would you add?
Yeah, I mean, I would I piggyback off of Dr. Fernandez. It hasn't been that different utilizing telehealth services, but it has been a little, for me personally, has been a little strange and awkward at times. But sometimes you just have to roll with the punches, and do your best. But you know, there are those situations where, for example, for me, where I may have an older client who is not familiar with utilizing internet-based or technological devices, and it makes it challenging for them to, because it's challenging to utilize those capabilities and the functions of technology. It does somewhat affect their willingness to participate. It may make them, it becomes a stressor for them. And that it may not be all the time, but for some sessions that may be the case. And you'll get those responses of, oh my God, I wish this was in person, just simply because that's what they're used to. Whereas for younger individuals, they're readily, I'm good to go. This is just what I need right here. I got the flexibility. I can do this real quick session with you. I can go back to my job, or be with my loved one, or attend to, another, child or loved one, or the pet, something like that. And it works for them. So it is, in that sense, on those occasions, it may be a blessing in disguise, but for other reasons, it may not be a blessing in disguise. It can do some serious trauma, and I don't want to toss that word around too fluidly, but it can affect them, and be a challenge for them. So there's a mixture. Now I'm also a qualified substance use professional through the Department of Transportation. And so, like Dr. Fernandez was saying, they're in person. It's important for me as a professional to pick up on those nonverbals, especially, if I'm needing to know that they have utilized or used a substance before, coming in at whatever point. And it's somewhat a difficulty when all you're seeing is their face, or just the upper part of like their abdomen on up, so that can be a challenge. And if I don't see them shaking, like Dr. Fernandez pointed out, it's like, okay, what are you doing, what's going on? It's those kind of probing questions that usually I wouldn't have to ask, whereas I would automatically detect that in person. So it can be not frustrating, but those are the things that, as a clinician, as a professional, that you have to always adjust or readjust for, or account for within whatever type of session that you have. Yeah. So.
Yeah, so definitely sounds like both of you have had to adjust the way that you work in certain ways. And that was a really interesting point you made as well on the accessibility. We tend to think of telehealth being more accessible for most folks, but there can be a subset who are not comfortable with the technology, where that actually makes it feel less accessible, and just being aware that that might be a factor for some of the folks that you are working with is a good point.
Mhm.
All right, and moving into our next question. So, how to engage the family in treatment, especially if the client who is struggling with addiction is resistant to involving them? So, David, I'll turn this one over to you first.
Yeah, that's a really good question. And I think Dr. Fernandez kind of pointed that out, with one of the other questions she had answered to. Where I took that, I should say. But it depends on the services and the modality of the program for me. The family may not be involved, which, that can be a detriment. But for me, or the way I see it, it's important to help the client understand that having a support system can be essential with uh, their stabilization, sustaining in their recovery, and overall, just their recovery process. where sometimes family is that detriment, like the family themselves are the problem, or they are leading to, I'm losing the word. They're leading to a relapse, So, and that could be a problem. But so I use support system because their family may not be blood, it may be a friend or somebody in their community or members in their community that help them, stabilize and live a healthier life. So to answer the question, whenever that person is comfortable with involving them, but again, the program may not warrant that or may not utilize that as an area, which it depends. But it's important that you advocate as a clinician and help the client understand that they too can advocate for themselves or involve people, their support system within their own recovery process. But advocating that they involve their support system to whatever capacity, especially if that's something that they really want for themselves. I hope that answered that question.
Yeah, and really nice distinction between how family and support could be the same, but also could be different individuals in that person's life. Jennifer, what would you want to add to this?
Yeah, I think if the client is resistant, I would want to assess that and understand why. So, as David pointed out, sometimes engaging the family, like biological family, would be contraindicated. So, if I can assess the system and determine that there are toxic dynamics that actually perpetuate this person's problematic relationship with substances, then I wouldn't want to involve them, and would want to help them identify the chosen family and that social support outside of a biological family system. So, I think that would be step one. If the family system is healthy, or at least can become healthy, then I really like an intervention called CRAFT. It's community reinforcement and family training. So that's another evidence-based modality, specifically for concerned significant others, for loved ones. So parents, partners, siblings, children. And so it's like a very structured way of helping people learn about addiction, learn the signs of intoxication, identify healthy boundaries to set with the person who's using drugs problematically. And really kind of focuses on how to reward the behavior that we want to see. So how do we reinforce behavior that we want to see from the person who's using drugs, and not really punishing behavior that we don't want to see. So not punishing or necessarily distancing ourselves from the person who's using drugs unless we need to do that for safety reasons. But really trying to promote like more connection, more compassion, more relationship with the person who's using drugs, so that offers a compelling alternative for them and helps motivate them away from problematic substance use. So CRAFT is a great modality to get trained in. And the book you can sort of train yourself or refer to, offer it as a resource to family members, is called Get Your Loved Ones Sober. It's by Robert Myers, I think is his last name.
Fantastic. Great suggestions there. Our next question, do you agree with addiction comes from childhood trauma? Jennifer, I'll turn this one over to you.
Sure. I don't think we can talk about addiction without trauma. I don't think that it necessarily stems from childhood trauma, although we do see that folks with higher ACE scores are at higher risk for addiction. So ACE being the adverse childhood experiences. But I think the SAMHSA statistic is like 90% of people with a problematic or like with a substance use disorder report a history of trauma. So that trauma could happen at any point along the lifespan. And so I think when we're working with addiction, we always have to think about it as a co-occurring issue. So in my decade of treating addiction, I have never seen a standalone addiction where nothing else is going on for that person. So I really think about the addiction more as a symptom of a larger problem. And so I have to get to the bottom of whatever that is if I expect to see any change with the substance. Yeah, I think that's all I want to say about it.
Yeah, David, anything you would add there?
I think Dr. Fernandez said that perfectly. Addiction, there can be many ways that an individual enters into the realm of addiction, genetics, environment, obviously, right? The development process, what's there in their community or, um, their world. But yeah, having understanding the ACEs is also an important, component to working with individuals with addiction. So it's not just about what's going on in the childhood, but there may be a lot of factors there that have led that individual to use. So no, I think that's perfect.
Yeah, so really hearing from both of you at this point that addiction doesn't happen in a vacuum. It's really important to look at the whole person and their whole spectrum of experiences and how that all works together. So moving on to our next question, what interventions are most effective to assist clients who've recently left rehab? David, I'll turn this one to you first.
Make sure I'm off mute. Interventions that are for individuals who, well, it depends on if they're just leaving rehab, then obviously they're probably at an outpatient program or some lower level of care. So you want to work with them. Dr. Fernandez pointed out, MI is always a good standard technique to address the readiness to change or where they are in their recovery. Other things, interventions are obviously, or therapeutic approaches is cognitive behavioral therapy. There's not one intervention or therapeutic treatment or therapeutic approach that is better than the other. What I found, most clinicians, most counselors, they like to utilize everything that they have available to them in their tool belt. As again, as Dr. Fernandez had pointed out earlier, and that's a good thing to have, is knowing many different types or having a variety of skill sets in your tool belt to utilize for that client, because no client is the same. There's no one size fits all model for that individual. So you want to, assess them where they are, and continuously reassess them for what's beneficial. And that may seem a lot general, but it really depends on that individual because no one is the same. But yes, what I found, MI techniques, engage, determining where they are in their recovery or readiness to change, cognitive behavioral therapy, approaching them with a client-centered, having a client-centered approach, and as a clinician, being receptive, knowing it's not about you, it's about that individual, building that rapport with them because this is their life, so that's my response.
Thank you. And Jennifer, anything you'd like to add?
Yeah, I think everything David said is right. It's good to have lots of different tools on your belt because folks are coming to addiction for different underlying reasons. And so you want to have a host of different interventions. And also, like he mentioned, folks are just different and are more receptive to different modalities. I think specifically to rehab, there are a couple things that come to mind. So agree that they should be in some kind of step down from inpatient care, whether that's usually that's an IOP or something like that. So they're still in therapy like 3 times a week at least. That's some combination of like individual and group therapy is usually most effective. They may also consider something like a sober coach. So I think, you know, a person who was in really serious addiction and then is coming back to the real world, which rehab is not, right? It's a very specific setting and environment. There's a lot of grief that can come up. There's a lot of change in transition. So having someone who's on call for you and can be there just to help you like set up your closet because you moved out of a roommate situation with people who were using and now you've got your own space. You know, it's going to help you get groceries. It's going to, you know, these just very practical activities of daily living that can feel really supportive and containing for someone who is going to undergo like a huge shift once they get out of rehab. So sober coaches, sometimes a sober living environment is a helpful step down. So not living on their own, living with a group of folks who are also recently sober, or you know, I think sometimes in a sober living environment, there can be folks in there who have been sober for quite some time, and that can provide a nice mentorship relationship for folks who are fresh out of rehab. And then I think a really important thing that I don't see too much of, and maybe that's just because of where I'm at, is overdose prevention. So, you know, really educating folks that, you know, the goal is for you to not relapse and your goal is abstinence. And if you get to a point that you really feel like that's not going to be possible to sustain, like here are the things that you need to know so that you don't overdose, right? Educating them on tolerance. You know, they're going to have to decrease their dose significantly, for example. Trying to see if you can get them to agree to use like less severe routes of administration. So if they were a person who injected drugs, you know, talking to them about maybe insufflating them instead if they are going to relapse. So doing some of that harm reduction education to prevent overdose is another really important thing that unfortunately I don't see a lot of out here.
Yeah, really fantastic point. And moving into our next question, what are some of the approaches to substance abuse treatment that are less used or considered, but still very effective? So I know both of you have spoken about and mentioned some of the modalities you commonly use, but anything that you think is maybe kind of overlooked in the field that you'd like to bring up here? David, I'll turn this one over to you first.
Again, piggybacking on Dr. Fernandez, sober living is something that is often forgotten about. And I live in California and I see more of it, but in Louisiana I did not. So you know, it's like it's often overlooked as a form of treatment, even though it's not as clinical, but it's still helpful. Like she said, it gives that mentorship for individuals who may have just been released from prison or jail, you know, or coming from somewhere where it was somewhat of a controlled environment, you know. The 12-step support approaches, those are or groups, those are still effective. Usually you get those, or people enter those, they can enter those by themselves. You know, you don't have to be referred or recommended by a clinician, but it's helpful to inform or instruct the client that that is available to them, especially if they don't have any knowledge of them, you know. Yeah, I would say, yeah.
Yeah, Dr. Fernandez, anything you'd add?
Sure. I'll stand on my soapbox and talk about moderation. So I think it's, you know, it's moderation is not a good fit for everyone with a substance use disorder. I think if you are working with someone who is, you know, consistently struggling with relapse, they're really resistant to changing their behavior with a substance forever, you know, abstinence just feels like this absolute thing that is unattainable and unsustainable for them, then thinking about moderation as a way to achieve abstinence can be helpful. And then I think just to add to what David shared about groups, there are a couple other abstinence-based peer groups that are free that are available. So there's Refuge Recovery. That one has a more of like a Buddhist lens and mindfulness meditation focus to it, which some folks really respond well to. And then there's also Smart Recovery. That's based on CBT. So we all know that that's an evidence-based modality. And then there are also moderation management groups that are free and peer-led. So if someone wants support, especially moderating alcohol, that tends to be the substance that most folks are seeking support with at meetings. I think if there's anything else. I don't think so. Oh, I do want to mention, excuse me, one more thing. Naltrexone. So naltrexone is a medication that can be really helpful for folks who are drinking more than they want to drink. So I often will encourage folks to check in with their psychiatrists about whether that's an appropriate intervention for them.
Great.
And I did want to point out with that one as well, going back to the support and family, there are groups for those as well. Even though, you know, we tend to overlook that, right, Dr. Fernandez? Like we tend to overlook that even if the family isn't involved or the support system isn't involved. Well, because the individual is going through so many changes in their life, that may also affect the people that are around them outside of the treatment system. So, you know, giving those individuals some type of support or avenues to receive care, or even the educational piece as well, you know, that's important.
Yeah, that's an excellent point.
Yeah, thanks for adding that as well. All right, moving into our next question. I find it difficult to rely on self-report. Besides self-report instruments and clinical interview, what are best practices? Jennifer, I'll turn this one to you first.
Yeah, I mean, I guess I was reading this one as more of a countertransference question. And I think I would want to know more about why it's difficult to rely on self-report. Again, coming from a harm reduction lens, this is all we use is self-report. So we don't do any kind of drug testing or anything like that. So I kind of thought about, I like put my supervisor cap on when I was thinking about this question, and thought about what if one of my supervisees or someone who came to me for consultation had this question. And I think I would want to explore just their countertransference with self-report, or with this population in particular. Maybe it's a specific client in particular, and kind of ask questions about trust in the therapeutic alliance and encourage the clinician to really explore that with the client. And if there are, you know, suspicions that the person isn't being honest, then how to broach that in the therapeutic relationship in a compassionate and non-judgmental way. But, you know, utilizing a client-centered approach, you know, that's kind of what we're working on, is building that trust and building that rapport so that the person can really come in and be honest. And that's going to help them work through the shame and stigma that they feel as a person who uses drugs. So I hope that I'm answering the question. I'm curious what David thinks.
I actually thought about that as well, because my clinical supervisor, when I had that concern, she said the same thing to me. Is this more of a countertransference, or is this a competency thing? You know, and so I will answer that if it is, or I will respond if it is, then knowing that the instrument that you're utilizing within your agency or for that population, it's usually, it should be a validated instrument. It's been validated. It's reliable. Knowing that much, right? Or if you're not comfortable treating that person, again, seek your supervisor, finding out why it is difficult for you to feel like you can't rely on the instrument, or what's going on in the interview where you feel like you're not comfortable in the assessment, or the evaluation process. So I kind of see why that question would be, broached. But the best practice for that is to, gain more competency. Again, brushing up on those knowledge, skills, and abilities, and speaking with the supervisor. That's the best way I can address that, because I too was on that other side at one point. But usually a seasoned and experienced individual can assist you with finding what best works for you, because every clinician is different, and that person that you're treating is also different. Maybe you're not familiar with their cultural background. Maybe there's some other bias there, but talk to someone, a professional, your supervisor, about that. That's what I would say. What is a good approach? Another approach.
Yeah, and I would just want to normalize that this comes up in this work. So it doesn't mean that you definitely shouldn't work with this population, or that something's wrong with you, or that you are incompetent, or anything like that. I think this is one of those growing edges in this work that we all face. And it's something that comes up in patient relationships, client relationships across presenting issue, right?
Great, thank you both. And our next question is, what do I look for in clients not presenting overtly with addiction or substance use issues that could be underlying? So any sort of thing that sparks you to maybe kind of look a little bit closer at that, or some signs that you might see that would be something you'd want to ask more about. Jennifer, I'll turn this one to you.
I think because my bread and butter is addiction and substance use, I always ask all of my clients about their substance use, even if that's not why they're coming in. So in my intake, I have like a really long list of drugs, and you put a little check mark next to it if you've ever used it once. And often folks are like, I didn't even know what half of those were, But getting that kind of history just kind of can already set off some, flags for me. So if I see that they've experimented with a lot of substances, that's just a question that I want to make sure that I ask them, not necessarily because I have concerns about addiction or substance use disorder, but I want to start gauging, like, what is their relationship with substances? How do they think about them? When do they use them? Like, are they engaging in safe, recreational, fun, beneficial use? Great. No, maybe they haven't, maybe they had a history of problematic use in the past, and that they were able to take care of that. That's all important information for me to have. And then I can kind of check back as things are happening and coming up in the therapy, to ask, like, oh, have you had any urges, or have you thought about using this substance, or you've been bringing up this issue, and I wonder if maybe one of those substances that you talked about in the clinical intake might be a way that you're trying to cope with this thing. So just having that info from the onset for me is really helpful. I feel like with substances, there are just so many physical things that could indicate that there's a substance use disorder going on. That just is kind of hard to rule out. So whenever there is something physical, medical going on with folks, I always encourage them to go see their primary care physician, and certainly we'll ask about sleep and eating and things like that. And I think once you get a little bit more comfortable working with this population, you start to make connections to which physical ailments could indicate problematic use of certain kinds of substances. But that feels so vast, that's not really something I think I can cover in the next few minutes.
which actually, as a note on time, we're coming up on the end of our time here. So this will actually be our last question for today. And now I'm going to turn it over to both of you to add in your final thoughts. So anything you'd like to share that we haven't touched on already today, anything you'd like to share with the group in general. David, I'll turn it to you first.
I would like to say those were some really good questions, and it was great being able to provide some information about those questions or give information for them. I've always found SAMHSA to be extremely helpful in guiding my knowledge outside of clinical supervision and education. They have a series of publications that are helpful for any budding counselor or addiction professional. There are several manuals that can assist you with guiding your practice and approach. Yeah, with the addiction and recovery population, normalizing, Dr. Fernandez, she made it very clear. The harm reduction practice or approach it doesn't work for everybody, but just helping them or knowing as a clinician to advocate for them and helping them know that addiction it doesn't need to be stigmatized or criminalized. Their life matters, and that's just me being empathetic and passionate about the work that I do, but it's not said enough. We are often looked at as, oh well, this is just the work that you found yourself in, but no, they're individuals, they're people too, and their life matters. So I want to end there, but good work, and thank you for all the work that you guys do, and thank you for having me.
Thank you. Jennifer, your final thoughts?
Yeah, I think that's just a really beautiful sentiment that David shared with us, and is really at the core of harm reduction, is really seeing people who use drugs as people first and foremost, and really bringing that compassion and empathy and non-judgment to the work. And it's funny how it's like the only disorder that we expect people to have figured out before they start therapy, right? Like, you got to be sober to do therapy. In most of the addiction treatment world, right? And so harm reduction is totally different. It's like, yeah, come on in, we'll meet you where you're at. And I have just found that work to be really, really beautiful work, and my heart is really in working with people who use drugs. Yeah, and I know that depending on where you're located, you may not have much access to harm reduction. In California, it's pretty abundant. So I did just want to share my educational website with folks, so that they can find some resources for themselves there as clinicians, but also for clients who might be interested in more of a harm reduction approach. And that website is poweroveraddiction.com. So a couple years ago, I wrote a harm reduction workbook under the same name. So that's available on Amazon, and is something, it could be a nice adjunct to therapy. And then on the website, I also have an online course for folks who might be interested in learning more about this approach.
Great note to end on. Thank you to you both so much for being here. It's great to have you. One last thing that I did want to mention is that for everyone who attended, there will also be an offer to get 2 months free of SimplePractice. So for those who are interested, those details will be in an email follow-up with a recording of this webinar, in case you'd like to reference it back as well. But just wanted to say thank you so much for being here to all of our attendees. Really appreciate you joining us today. David, Jennifer, thank you so much, and have a great rest of your day, everybody.
Yeah, thanks so much for having me.